our past chairpersons, our past chairpersons of Adolescent Health Academy, who have brought the legacy of AHA to such a great level that we are all finding difficult to really catch up. But we are, I'm sure, with that whole team of AHA, we will definitely work more harder to get the name of AHA at the national level. Um, So this is a very important. Today we have a very important two events, and this is a Silver Jubilee year, and we are celebrating this throughout this year with the guidance of our seniors and with the support of our all our colleagues, the OB, EB, and the young colleagues throughout the country. And some of the important innovative things we started this year is involving the youth in all our forums, in all our programs to understand their perspective. This has caught the attention of UNICEF, and we are going ahead to see that we can declare 18th of every month as a Youth Wellness Day. So this is going to be a very big landmark in the history of AHA and IAP. So this is one very big achievement which you are going to have. Second, the small steps we are taking to again motivate our members to start some adolescent dedicated spaces in both government and private sector, because we have been doing lot of capacity building over the last many months and many years. In 25 years, many modules we have run through. It is time for us to start spaces and centers throughout the country. Third is we are also trying to do advocacy on social issues on adolescent health, and we are also going to focus on this academic programs as we always do. And this time we have taken up super specialty topics, which are little bit away from the routine topics of adolescent health. And adolescent today, our team, which is taking care of the uh, journal, which is actually a bulletin, but it has very high standards like a journal. And we are also going to initiate our journal anyway, read, look at it and try to renew our journal with the help of the seniors and our colleagues in AHA. But this edition of AHA, it is called Adolescent Today under the leadership of Dr. Poonam and Dr. Gayatri. The whole team is doing such a wonderful job, and it's bringing in a lot of topics, especially on surveys and research also. This is something I think we need to capture the data and the profile of adolescents all over the country. And the team led by Dr. Poonam is capturing the data of adults, a profile of adolescent health through surveys, national-led surveys. We need to really give a big round of applause to the team, Dr. Poonam, and the whole team of Adolescent today. They are going to release the second issue. Dr. Poonam? Yeah. And we have none other than Dr. MKC Nair sir and Dr. CP Bansal sir for launching this edition of AHA Adolescent Today, this today. And before we start our super specialty webinar, we will be having this inauguration and launch of this important bulletin. And we also would like to appreciate that this after the launch, we are going to talk about psychiatric common problems in adolescent. And we have this panel discussion and the youth perspectives also coming into this webinar. I request all the members to please join in large numbers in all our programs in future, and all the best wishes on behalf of AHA to the team of Adolescent today for launching the second issue. And this is basically, I think, focusing on screen times also. Poonam will speak about it. I request Dr. Poonam to speak about it and invite the guests of honor, Dr. MKC Nair sir and Dr. CP Bansal sir, to launch the bulletin.
Yes.
Over to you, Dr. Poonam.
Okay. Thank you. Thank you, Dr. Hema. To respected dignitaries on the dais and all the delegates who have joined today's session. AHA has always been starting some or the new things for IAP. So this time, like from the time Dr. Hema has taken over, AHA has started a new culture of releasing the journal in a very mega event like a way. So this is basically not for the team. It is basically to honor all the writers who have contributed or who have worked hard to contribute for the articles. So before I proceed, I would like Dr. MKC Nair sir and Dr. CP Bansal sir, along with Dr. Preeti Galgali, to launch this journal. MKC sir, CP sir, Preeti Dee.
It's a great pleasure for all three of us, including the chairperson, fourth person, to release this special issue of Teens and Screens. I think it's a beautiful work. I have not seen the final version, but I have seems to have seen little bit of tidbits of that. My only comment would be in the front page, the patrons when you are put it in the sequence of the presidents. That may be nice because there's a lot of things. Well, only because this is a later on somebody will look at it as a official version of the academy. So I think just check on it. I myself is not sure, but
Sir,
I think there are some
this time we
mistakes.
had done that change. This
No,
time
I
we
think
had,
it's, even now it's not a correct one. Just
Dr.
check on it.
Okay, okay.
Just check on it.
Yes,
Okay.
yes, yes. Okay,
Thank
okay.
you. Benson,
Thank you.
sir.
Thank you.
Sir,
CP sir.
sir, respected MKC Nair sir, Chairperson Dr. Himabindu ma'am, distinguished guests, esteemed colleagues and dear friends. It is with immense joy and a profound sense of nostalgia, I'll tell you why nostalgia, that I appear before you today, looking out at so many familiar faces. I am transported to the vibrant days of Gwalior Adolescent 2003, when at that time the seed of an idea, a mere flicker in my mind, began to take root. And that idea, as many of you will fondly recall, was the birth of Adolescent Today, the official bulletin of Indian Adolescent chapter of Pediatrics. To see Adolescent Today being relaunched today with the distinguished presence of respected MKC sir, a true fatherly figure to the AHA and a past chairman himself, fills my heart with indescribable pride. Respected sir, I'm sure you will remember
Yeah.
those conversations and those discussions and those passionate questions which I put before you and respected madam in 2003, and you very happily, both of you agreed, and that Adolescent Today was born. It was a shared dream, it was a collective aspiration, and I am eternally grateful for you both for having your unwavering support and believe in that nascent idea of our team in Gwalior. For 15 years, Dr. Poonam and the chairpersons, we continued its publication from Gwalior without even a rupee from Central AHA. And many issues were also said by mail. You must be remembering that as well. It
Yes.
was a labor of love, a testament of our collective commitment to this crucial demographic. And also, those 15 years, I had the honor and privilege of serving this as its editor in chief. Every issue was a journey, every article a step towards a deeper understanding of adolescent mind and body. It was truly one of the most rewarding experience of my professional journey. Today, as we relaunch Adolescent Today with amazingly timely and relevant theme of teens and screens, I am reminded of another conversation with Sir and advocacy that I passionately championed years ago, the significant impact of media on adolescent, media boon or bane. That was uh, I used to give and take this topic way back in first half of this century, first 5 years of this century, I'll say. And it was clear then and is even clearer now that the digital landscape plays an undeniable and often complex roles in our young people. Therefore, friends, it is with particular delight that I find myself a part of this event. The theme Teens and Screens is not just current, it is complex. In an age where digital interaction often supersedes face to face communication, understanding the nuances of screen time, its benefits, its challenges, and its long term implications is paramount for parents, educators, and the healthcare professionals alike. A special thanks, of course, are due to Dr. Hema Bindu Singh, our current chairperson. Her vibrant leadership and dynamic vision are truly commendable. उनका रियली उत्साह और उनकी नई सोच एएचए को नई ऊंचाइयों तक ले जा रहा है, हम सबको दिखता है. Also, my heartfelt appreciation to Dr. Poonam. She gently yet persistently encouraged me to contribute to this and give a write up. पूनम जी, आपकी लगन ने मुझे लिखने पर मजबूर कर दिया और लिखने का आनंद भी दिया.
Okay, sir.
I am confident that this version of Adolescent today will become a strong platform for sharing ideas, experiences, research, and innovations. Let us all support it with our writings, thoughts, and time. चलिए मिलकर एक बार फिर एएचए को नए रंगों से सजाएं. Warm wishes to entire editorial team and AHA leadership. Thank you all. Jai Hind, Jai IAP, Jai AHA.
Wow, wow, wow.
Thank
Only,
Wow, sir.
only
you, sir.
Bensel
You
can do
you
such a speech. Superb.
superb,
Superb.
sir. Superb. It was so touching,
Huh.
and every word you spoken was so appropriate. Thank you, sir. You really made AHA, and all of us are working towards AHA. We really got connected with your words from those days of 25 years back to
Yes.
now. We are all together, sir. Thank you.
वो एक्चुअली पूनम जी ने मुझे 2003 में पहुंचा दिया. सर को याद होगा जब सर वो भी आए थे आपके साथ तमिलनाडु से.
Oh, the psychiatry girl?
एम गणेशन सर.
Ganesh.
Yeah, yeah. Ganesh. Yeah.
So nice memories, sir. Thank you. I think the idea of capturing your messages as chairpersons, past chairpersons, yeah, and including a video of your thoughts, this will always be in the history of AHA.
Yes.
We want your
True.
thoughts to come in, sir. Thank you so much. Over to you, Poonam, again.
Just few words from Dr. Preeti, and then we'll just
Yeah.
scroll so that we can have our webinar.
Welcome you, Preeti ji.
Thank you, Poonam. It's a pleasure to be here in front of my two very special mentors, Dr. M.K.C. Nair sir and Dr. Bansal sir. And in fact, under their guidance, we have been able to keep this legacy alive of our chairpersons, our founder chairpersons and founder members. I always have held that Adolescent today is the voice of AHA and also the voice of the youth, and is so very important that we keep this voice clear, loud, and booming. And everybody, the whole world knows about AHA through Adolescent today. So thank you very much. And I wish Poonam and her editorial team grand success in all the issues and years to come.
Thank you. Thank you so
madam.
much.
Thank you.
Should I scroll through?
Yeah,
Few-
please, Doctor. I think
Okay.
let us all come together and give a
Yes.
big round of applause to the team as Dr.
Yes.
Poonam will
Yes.
release the second bulletin of AHA. Over
Thank
to you,
you. Thank
Poonam.
you.
Lot of hearts and
Thank you.
going up. Yes.
The
Please.
chairperson's message you have already received. Dr. Hema wanted to say about the standard operating procedures for your adolescent clinic, parenting guidelines. She has already spoken about it. And now the cover page. You must be wondering what
Are you
screens and
sharing the screen?
I
Yeah.
can't see.
Screen
You
share
can't
nahi ho
see?
raha.
Not
Yeah.
me, ma'am.
Poonam, I think screen is not properly shared.
Someone else has shared some, we can see
Zoom is there in between.
M.
Okay.
Rishikesh screen.
now
Nahi, no.
I think someone else is sharing the screen. They have to stop sharing. Then you will be. This
Okay,
is the
should
screen
I
of
stop?
M. Rishikesh screen. I can see.
Should I stop and then reshare?
Yes,
They have to stop, Rishikesh.
Okay.
Rishikesh. Yes.
Initially, it was visible or it was not visible from the
Not
start?
visible.
It
not
was visible.
visible from
Initially, it was
beginning.
visible. For some time, it was visible.
Right now?
Yes, now. Let's see.
Yeah.
Now it is.
Yeah,
So
yes, yes.
visible?
Now it's
Okay.
okay.
So we had this editor, the chairperson's message, then the editorial. So
Poonam, aisa little bigger size, little more bigger size.
you must be wondering what the fields and screens and the tree with sunlight has a correlation. So this is again derived from a Japanese philosophy and a Japanese word that is komorebi. This is the word which they use for the filtered sunlight through the shady trees. The light reaches the ground so softly and it is not at all glaring. This is how we want the screen light should reach our adolescent, and all the dress details you can go through the editorial. Then in our Silver Jubilee Chronicles, we have Dr. M.K.C. Nair, sir, whose monumental and visionary work all of us have witnessed since past more than 25 years. He has not only developed screening tools, he has started PGDAP course. From neonatology to adulthood, he has contributed or he has written so many books. We truly bow towards you, sir. And all of you must go through the article which he has shared with us, his journey, and what he plans for future. Then in Silver Jubilee Chronicles, we have featured Dr. C.P. Bansal, sir. He is strong, yet a very grounded leader. He is deeply committed and remarkably humble. You can all go through his article and you can witness his humbleness. Next, we have an article. This article is contributed from Nimhan's Shut Clinic, and Dr. Geeta Patil, she helped me in getting this article. So thank you, Geeta, for getting me this article. The Shut Clinic, for those who don't know about Shut Clinic, it is services for healthy use of technology. This is the only clinic, the first clinic in our country, which is being run by Nimhans. And the article is on internet gaming disorder in Indian context. Then we have an article from a cross-sectional study from Dr. Kusum Kala, impact of sleep on academics in the students of Jaipur. This is the next article which has been contributed by Kusum. So I was telling everybody this time we have 3 psychologists on board. Dr. Shrestha Chattopadhyay, she has contributed for the case discussion of impact of screen on teenager. Then not all technology is bad. So how it is good or the positive screen usage for the teenagers, this has been contributed by Dr. Aparajita Das. We have some giggling moments or maybe nostalgic moments. We have taken articles when the summers meant stories from our seniors here, Dr. Kiran Vaswani, Dr. Rishmi Gupta, Dr. Umesh Khurana, Dr. Avinash Bansal, and Dr. Harinder Singh. They have shared how exactly they spent their summer holidays. Sonia, would you like to comment on the boxy screens and breezy summers, the stories from those who are born in 90s? Sonia?
So, ma'am, we wanted perspectives. Like, first was from the female when the screen was not available, and they had like, they were spending their holidays with friends and nature. Then we took viewpoint of some younger generation, like a postgraduate senior residents, where there was presence of screen, but still how, because that time there was not so much impact of screen, how they still with those screens they would see a little TV and they would still take out time for other activities. So this was a mix and match. So we just thought like, and probably sometime later we'll get the Gen Z
Yes,
views
yes.
also, that how now they are spending their holidays.
Spending
So
their
that
summer
was the vision behind this, ma'am.
Thank you, sir. And then we have the article from Gauri Samyaji, Gen Z Lingo. So all of you should go through this article, because then you are going to learn a lot of new vocabulary which our Gen Z contributes, or what they talk about, how they talk about. It is difficult to catch up to their level, but at least few words we can definitely understand. Then the second psychologist, now this time contributed as parent, Dr. Shikha Kuchal from Gurugram. And she has just spoken how she trained her daughter, or how she trained her daughter to use screen judiciously. And there's a section where her daughter also shared like what problems she faced when she was not using social media so openly. The third psychologist we have, she's
Dee, I want to take a moment to
yes,
thank
Shikha.
you for, yes, I really want to take a moment to thank you for giving me this opportunity, like a small brick on the wall that you've created over the years, because that's what I've heard from Sir C.P. Bansal about you and your team. So for a someone very young like me, it's very profound. And I really want to thank you for this. Thank you so much. It means a lot.
Thank you. So the third psychologist we have, Garima Gupta. She's a psychologist at Pune, working in as a counselor since past 17 years. And you can go through her profile. It's amazing. She has won so many awards. So suddenly, since we were having very little articles this time, I was struggling to find out people who can write a book review. But Garima's father-in-law, he is 75 years old, and he's our partner in aerobic classes. So I have heard that he keeps on talking about his daughter-in-law. So I requested Garima, can you contribute to something? She said, I have written a book. I'll write a summary of that book. And wow, I think everybody should go through this book, The Body Nirvana. And another good connection, she is sister of Dr. Gaurav Gupta from Chandigarh. This was an amazing connection. And I think as we age, we start believing on universe, that universe do listen to your voices. And as we close down, here's the activity report from April to June. AHA members, they are doing amazing work. Almost 305 activities have been conducted till now. And just in 3 months, 305 activities, this should be given a good applause. And Sonia, you have compiled this glimpse of activity, so you can speak about it.
One we have the summary, and then the glimpse of activity. So this has been going from east, west, north, south. So lot of contribution from Alpna Shukla.
Yes. From Navi Mumbai, Alpna Shukla, and then from Gwalior Adolescent Health Academy. And this is the Wave 18 report. They have different themes every month, and every month a different poster is released based on which sort of activity they want to conduct. I care for you from day 1 to 18 years. I'm your pediatrician. I think this is the poster to be released soon by AHA, but Dr. Avinash Bansal sir, he requested me to publish it. So with due permission of Dr. Hema, we have published this. And
Please, yeah.
all of you are invited for AdolesCon at Ahmedabad. Thank you. Thank you, everybody.
Thank you, Dr. Poonam. That was very great. And so I think we should celebrate this. This journal is one who connects all of us, all the seniors, colleagues, young people who are being inducted into AHA, into adolescent health. So this will give us them an idea of the work done over the last 25 years. Very important issue, and especially the way Dr. Poonam is spearheading the topics are so excellent, including research, surveys, and also connecting with each one. The topics chosen are so good. Really, thank you, Dr. Poonam and Dr. Sonia and Dr. Yatesh, all the section editors, and all the whole team for
Yes.
such a successful launch of this issue.
Yes.
Thank you.
Thank
Kudos to all of you. Thank
Thank
you.
you to my team, and thank you to my digital partner too. Thank you.
Yes.
Thank you, Smita.
Thank you. Thank you. Now I request Dr. Arya. Thank you, Dr. C.P. Bansal sir, Dr. M.K.C. Nair sir, for having been with us and launching this very important issue for all of us. Thank you so much.
Now I invite Dr. Sudhir Misraji for further proceeding of today's webinar, that is IAP-HA Super Specific Webinar. Dr. Sudhir Misra, sir.
Thank you, sir. Thank
Sir.
you, Dr. Arya.
Sir.
And congratulations to the whole AHA team, especially the editorial board team led by Dr. Poonam Bhatia for the wonderful work that they have done. Now, today's super specialty webinar is on adolescent psychiatry. And we have with us Dr. Manoj Kumar Sahu, who is the HOD psychiatry at Tata Main Hospital, Jamshedpur, the hospital where I used to work before my retirement. And Dr. Manoj Sahu has since beginning been very much interested in taking care of adolescents. And I know for sure that he has prevented many suicides among the adolescents. He is an MD from NIMHANS, and after that was a faculty at Indore, and after which he joined Tata Main Hospital and is continues to work there. And the second person I would like to introduce is Dr. Ramesh Dampuri, a very well-known active pediatrician, an IAP member, executive board member, and the executive board member of the AHA, who will be moderating today's panel discussion with the experts like Dr. N.C. Prajapati, who is currently a Vice Chancellor of University at Mathura, Dr. Joy Bhadri, who is a community pediatrician from Jamshedpur, Dr. Anirban Ray, who is an adolescent psychiatrist, did his DM from NIMHANS, and Dr. Rishikesh, who is a clinical psychologist. So detailed introduction of these will be done by the Ramesh Dampuri sir. And Dr. Jalil will, of course, he is again an EB member of Central IAP. So Dr. Jalil will be carrying out the interview with the adolescents. So I invite Dr. Manoj Kumar Sahu to start his lecture, after which Dr. Ramesh Dampuri for the panel discussion.
So thank you, Sudhir Misra sir. Sir was my boss when he was in our hospital. So just a correction, I have done my MD from PGI Chandigarh, and I have also done my MD senior residency from PGI itself. I'm working as a head consultant and HOD in Tata Main Hospital, and I'm working here since last 15 years. I'm also heading the Department of Psychiatry, Manipal Tata Medical College, Jamshedpur. So I'm very passionate about adolescents because actually for parents dealing with them, it is very, because they're not trained. So the adolescents actually, they're in training. They need a lot of guidance to guide their life, which is very crucial at this juncture actually. So I'll share my slides, just a minute. Just a minute. Is my screen is visible now?
No, no, Dr. Sahu. Meanwhile, while you look after your screen, I apologize to Dr. Preeti Galgali, who is the guest of honor today, a Vice President of Central IAP and an internationally acclaimed adolescent physician, to say a few words while Dr. Sahu sorts out his slides and presentation. Dr. Preeti Galgali, ma'am.
Thank you so much, Dr. Sudhir. It's a pleasure to be here among stalwarts of AHA. Thank you for inviting me. Dr. MKC sir is here. It's always an honor to speak in front of him, and also Dr. Bansal. Thank you, Dr. Hima Bindu, Dr. Sushma Desai, Dr. Geeta Patil, Dr. Arya, and the entire team of AHA. We all know adolescents form 18% of the Indian population. And during COVID, we have seen that mental disorders have increased from 7% to 14%. There is absolutely no health without mental health. And when we talk about physical disorders, for example, diabetes, epilepsy, we know how important mental health is for this as well. Because adherence, which is so very important and which is actually goes down in the adolescent period, cannot be really maintained if there is no mental health. We also know that 50% of the mental disorders present before 14 years of age, and hence as pediatricians, we need to have our antenna up. It is often said that 70% of the adult mortality is due to causes which start in the adolescent period. And we all know this is so closely related to adolescent health, that is stress, to mental health, that is stress management, tobacco use, obesity, poor physical activity, because these track into the adulthood and lead to non-communicable diseases. Mental health follows a spectrum, mental wellness on one hand and mental disorder on the other. And in between, there is mental distress. As pediatricians, we have a great opportunity to intervene and make sure that the mental distress does not end in mental disorder. And to end it all, as a clinical flat point, I would say, never ever look down upon poor academic performance, because poor academic performance can be a very strong pointer towards mental distress and mental disorder setting in. I wish this webinar grand success, and we cannot, pour from an empty cup. I would request all pediatricians here to look after their mental health as well. And that is what was the theme of the National Doctors' Day. May you have a very happy and fulfilling adolescent practice. Thank you very much.
Thank you, ma'am. And now I invite Dr. Manoj Sahu. Just make it fully screen, Dr. Manoj, and go ahead. Once again, my apologies to you, ma'am, for not inviting you earlier.
No problem, sir. That's absolutely okay.
It's visible now. It's full screen. It's visible, Dr. Manoj. Please start.
Sir. So,
Dr.
yes,
Manoj,
all of
probably
us.
you are from iPad or it's
I'm
Mac.
from sir, I'm MacBook, sir.
Therefore, that is the issue. No issues.
Sir,
You are quite visible now.
Yes, sir. Yes, sir. Actually, so we all know that I'll not spend much time. It is already late. So we all are aware that the adolescent is a time of transition and change, and the adolescents are actually adults in the training period actually. And during this period, they go tremendous change in terms of their hormonal changes, social changes, emotional changes, and spiritual changes. So parents and as a doctor, we need to understand that this is natural to have changes during the period of adolescence. Sometimes we interpret those things in a different way, but this is natural to have changes during this period. So these are basic problem is that they seek autonomy, and there is a asymmetrical relationship with their parents, because before the age of 10 they are very close to their parents, and suddenly they separate from their parents and seek autonomy, and they try to establish their own identities and their own value system, which can be different from their parents and which can be different from the school's ecosystem. Therefore, there is very fair amount of chances that they can have conflict with the environment, and that's create the problem, and they go into emotional disturbances because of that. So just briefly, I'll touch upon the changes the teens actually they go through between 10 to 18, because there is increased influence of the peer group during that period, and there is specific desire for independence and autonomy without taking much responsibilities, and there is natural tendency to distance themselves from the parents and continue to drive for the independence, and of course the feeling for the love and passions that becomes, and their priority sometimes changes from the academics to the relationship, and so that creates a little bit of problem in the family environment, because traditionally we have seen that the academic pursuit and academic excellence is considered as the success even during adolescence also. So this is our society and our culture. We only think that if the child is doing well in the academics, they are very good. Even if they are not doing well in the academics, then there is a problem. So that mindset we have to change among ourselves, and also we have to educate the parents. They have to change their mindset. So emotional safety in adolescence is very important, because when we talk about cyber safety, we talk about road safety, we talk about other safety. So being here in Tata Steel for last 15 years, we talk a lot about safety. So 15 years back when I joined here, so we took a drive of talking about emotional safety in all the schools of Jamshedpur. So it is a container particularly that holds the space that allows the children to feel, to be curious, and to be care and emerge as their unique selves actually. So if we can provide that environment either in the school or in the home, then the child will definitely nurture themselves to grow as a person with their independent aspiration, and they can value themselves with their own value systems. So definitely when the child is emotionally unsafe, or the emotional safety, it affects the mental health, which all the panelists will talk about today. It has tremendous effect on the relationship the adolescent will have among the peers, with their teachers and the parents, and definitely it will help in their academic success also. So it is very important to have the child emotionally safe, so that all these aspects of his mental health, relationship, and academic success, all these things will be flourish. So when particularly we get worried, when the child suddenly there is a change in his personality or his behavior, so then we can think that the child is going through emotional disturbances, or the adolescent is going through an emotional unsafe period. When suddenly you think that you observe the child is withdrawal from the family and friends, he is isolating themselves, avoiding social interactions. There is irritability, anger, frequent outburst of sadness or weeping. And suddenly there is a drop in the grades, a loss of interest to go to school. Sometimes they present with school refusal also. And they often present with unexplained physical symptoms. Normally, lot of referral we get from our pediatrics department when there is unexplained, basically physical symptoms, because as a child and adolescents, parents are very emotional. So you cannot ignore them. They go on, they investigating, they're over investigated, and we don't find any explained reasons, medically explained reasons for the symptoms. Then we should think that child is going through emotional turmoil or disturbances. Of course, these days the behavioral addiction in terms of either internet or other substance is a very important indicator that child is going through emotional disturbances. So because when sir told me about, you should briefly talk about how we can prevent this occurrence of these emotional disturbances. Because as you know, this is a multifactorial things, because the child born with a innate genetic temperament, which is innate and which is the child is not responsible for. So sometimes because of that temperament, there is a problem arises in the environment, because when that temperament interact with the environment, there is some problem. And when we do not understand his or her temperament, then there is a problem. So it can be biological or genetic vulnerability, it can be temperament, it can be family environment, it can be situational factors like peers and school environmental influences, like bullying, academic pressure, social media comparison. All these things are clearly influencing our adolescents these days. And of course, early life experience in terms of abuse, trauma, family discord, attachment problem in the family, so loss of parent or grief in the early childhood. These affects the personality and of the child, basically, that manifest later on when they face the environment. And of course, sociocultural factors, because as we know, during this period, their body image, their gender, all these things play a big role to shape the child, and also that clearly affects their psyche during the adolescence period. So I'll describe certain case vignette so that you can, I can just with my, all these cases are live cases treated by me. So I'll just elaborate few cases to demonstrate how we can prevent this emergence of these behavioral problems in the adolescents. So first case is a 11-year-old girl studying in class 6. She is above
लहसुन की
studies,
स्मेल आ रही है
and she came to our child
लहसुन
clinic.
लहसुन
So somebody is talking. Nirmala madam,
देखो जो प्रोमिनेंट
please
स्मेल
mute
है
madam.
दरवाजा खोलते ही आती है
Nirmala Joshi madam, please mute madam. So a 11-year-old girl.
Dr. Nirmala Joshi, can you please put?
So with complaints of school refusal, particularly she presented to us. So initially the parents were not oblivious. They are not understanding why suddenly she was academically good, why she has stopped going to the school. So on exploration, the child was not coming up. After spending some time, few sessions with the child, then she started speaking about that. Suddenly there is a section change in the 6th class, and she is now facing challenges, finding new friends. She's feeling isolated in the new section, and she's not finding it motivated to go to the school. And at the same time, and parents, it's okay, she was good, so they're thinking that there might be some other problems also. So why I'm talking about this, when we talked about her temperament, early childhood, we found that she was a shy temperament child, slow to warm up, low self-esteem. So when there is some problem in the environment, they go into their cell, basically. The second child is a 14-year-old boy, class 9, very good in studies, came to our clinic with complaints of irritability, impulsivity, procrastination, poor anger control. Suddenly, when he is promoted to 9, particularly in the 8th class, there is a lot of behavioral problems, their complaint from the schools. So actually, when we explored, that child was actually hyperactive and has a difficult temperament from the childhood. And the teachers and peers perceive him as a negative, and they do not appreciate his efforts, because he is now, basically he's growing in a negative environment, and now he's exploding. The parents are not able to handle. That is the reason they have come to us. So just diagonally opposite temperament, they're manifesting in a different form here. So one is school refusal and other is manifesting as a externalizing behavior. So we should understand that they can manifest, adolescents when they're challenged, they can manifest as an internalizing disorder or they can manifest as a externalizing problems. So particularly when we talk about temperament, particularly the adolescents who have slow to warm up temperament, shy temperament, anxious temperament, or the avoidant temperament, they normally have a negative self-concept. They overthink about a lot of things. They have high emotional sensitivity. So our approach towards this group of children will be different. And while dealing with the externalizing problem like ADHD or defiance problem, they have low frustration tolerance, they are sensation seeking, they have poor self-regulation, so they can always present with disciplinary problem. So our approach to this group of children will be different. So how our approach should be different, because while talking about dealing with these two temperament, diverse temperament, which is the common I have and we normally encountered in our clinical practice. So the aspect we should focus on emotional regulation, communication, behavioral reinforcement, parental techniques, and school support. So all these are very important because the etiology is multifactorial. So the management should be multifactorial. Only talking to the child, empowering the child will help, but at the same time, we should guide the parents also. We should influence the school to modify. We should engage with the teachers also, and also change the milieu and cultural belief the parents have, so that we can help the adolescents so that they do not manifest in a full-blown emotional disturbances. So the first child, our approach should be, we should teach him calm down routines, mindfulness. We should have open communication, encourage expression and feelings verbally or through art or through music. So all these things will foster a group feeling. Suppose we encourage them to join some music, art, they will find spontaneous friends there, they will connect there, they will express their feelings. And of course, we should reward the efforts to face anxiety, providing stressful situations. And the parental technique, we should avoid overprotection. We should not foster dependency, because they will be clinging to us for every decision in their life. So in the parenting aspect, we should be supportive. At the same time, we should not just we should not hold his hand always. No, we should foster dependence. And at the same time, we should not be very controlling also. We should not be losing our temper while dealing with the children. That will further deteriorate their conditions. And of course, school support, peer support, and group work will help this group of children. While talking about the other children, particularly who has externalizing temperament, here in the emotional regulation, we should work on his anger management and controlling his impulsivity. We should encourage him to outdoor sports. And at the same time, we should have clear and consistent instructions. Particularly in this group of adolescents, we should focus more on relationship, character than academics. We should focus on his behavior rather than the person. What happens in this group of children, normally they are victimized. So you are doing this, you will not do anything in life if you continue life. So when you pinpoint the adolescents like this, their self-esteem become very low. The externalizing manifestation become more prominent. So this group of children, relationship with the parents is very important. Otherwise, they will go into addiction. Otherwise, they will have personality disorder. They will go into behavioral addiction, substance abuse, all these things. So character and relationship building is very important in this group of children, rather than just focusing on the academics aspect and on the disciplining aspect. Because sometimes we have to accept that this child has a different temperament and we have to accept some amount of problem, and we have to guide him through good and positive relationship. That is very important. And we should avoid physical punishment, verbal abuse, name calling. All these things are very important, and we should reward the good behavior through responsibility. If we give responsibility to these children in the schools, they do well. If you only punish them, if you suspend them, then their self-esteem will be low and they will not grow. They will go into the different path. So coming to the another child, particularly you all are experiencing or must have seen in your clinical practice, a 14-year-old girl studying in 9th class presented to our clinic with recurrent episodes of fainting episodes. Particularly, we called it dissociative episodes. She has been evaluated by various pediatricians and neurologists, but there was no neurological basis and there was no physical reasons for the same. So on exploration, after spending time for 1 or 2 sessions, so she clearly told that she is in a romantic relationship with a boy and she is very serious about that relationship. And her priority is now the relationship, but she's scared the family member will come to know, then it is not encouraged in the family. And it's clear that she's in conflict with herself. So when she's having dissociation, she's gaining a lot because she's getting a lot of attention from the family member, and family member are very worried about her health, but they have never discussed all these things because this is not encouraged in the family. So it is very important to have an open communication. And the other part in this family was they're very controlling. So with this, I need to emphasize the parenting aspect here. Sometimes in the family environment, in the internalizing disorder, particularly when the person is having depression, anxiety, dissociation, or multiple somatic complaints, you'll find either the parents are emotionally distant or uninvolved or overcritical parenting, or there is loss or neglect, or parents themselves are suffering. So all these things may lead to such kind of problem. But in externalizing, there is inconsistent, harsh discipline, family conflict, violence, low supervision. All these things can manifest as an externalizing problem, as I have already discussed. So little bit I'll touch upon the parenting aspect. As you all know, there are 2 aspects of parenting, like warmth, responsiveness, love, and other aspect is control. So broadly, when you talk about dealing with a shy, anxious, avoidant child, the warmth, love, support part should be a little bit more prominent rather than the control part. And while dealing with a externalizing behavior child, the warmth, love, and support and control should be equally present. If your control part will be heavy, then you will have a poor relationship. You will spoil the relationship. Once you spoil the relationship with the child, then you cannot control. It will go out of control and it will lead to a very adverse consequences. So I'll not go into the details of the type of parenting. We all know about it. So after talking about another 2 vignette I want to discuss, when the child is facing with the own expectations and peer pressure. These are the 2 examples. Just recently, a 15-year-old 9th student, the topper in the 8th class, he was studying in CBSE school. Suddenly, when he went to 9th, he requested his family member to change the school. Parents were very surprised. He was doing well in the 8th class. Suddenly, in the 9th class, why he is asking for it, he was adamant, and parents succumbed to his demand. He applied and gave the entrance in a ICSE school, and he qualified also. He joined the ICSE school. And after that, after going 3-4 classes, he's just after vacation, he's not going to school. He's just going now into cell. He's spending a lot of times on the mobile, not going to school. So they were surprised what happened to their children who was doing so well. The parenting aspect was good, but he has visited many doctors. He was diagnosed with depression. He was voicing suicidal thoughts also. So when I interacted with the child, I found that child was actually struggling to sustain his position. He thought that in ninth he cannot. So he thought that maybe changing in the school he can give you explanation. There were more good students there. But when he went there, he found that it is difficult there. Different school, different syllabus. It is more difficult there. Then he started avoiding the school. So it is very important to understand that what the child is going through. So here it is important to work with the child, his expectations, calming him down, decreasing the parents. So parents' expectations were not that. So it is important. Sometimes we have to work with the child. It is very important. Coming to the second child, this 15-year-old boy, again, his parents were transferred from a different city. He was a topper in his class when in the different city when he joined here in a prominent school in Jamshedpur. Now he is finding very difficulty in finding new friends here. He's struggling with the academics. He's not finding that he cannot cope up with the academic stress here. He cannot be the topper here in this school. A lot of other students are there. So desperately for peer acceptance, he started smoking, joking. So this is very important that what the child is doing, if our relationship with the child is not good, we are not openly communicating with him, we are not spending time, we will not understand all these things. So because they have come to us, we have spent time, we have taken the child into confidence, so we can explore all these things and guided the children. So it is very important to know how we can deal with this kind of adolescents who day in, day out, they face this academic pressure. So it is very important to have open communication. We need to help them to prioritize and organizing study, encourage healthy study habits, teach them stress management techniques, creative outlets, suggest hobbies like drawing, music, writing, even sports, set really realistic expectations. There are a lot of children, they come to us with unrealistic expectations. I don't know, maybe parents, they do not on they gain these expectations from their peers, from the society, from the relatives, but they have their expectations. When they find that it is not they're getting that result, they totally choose a different path. Encourage social connections and educate when to seek help. This is very important because of the taboo about talking about mental health, they do not seek help. But nowadays, a lot of parents are seeking help because we are not only, because these things cannot be only handled with medication. Sometimes we will write medication when the symptoms are severe and we cannot handle with only counseling. But we need to educate the parents that only guiding them through these forums and we can guide them and they can have a better health, mental health particularly. So helping the adolescents with peer pressure is also very important. So you need to understand.
Manoj,
Yes, sir.
please,
So last slide, sir. Last slide, sir. So we need to recognize the signs of peer pressure. We need to foster open communication. We need to help them to build confidence. We need to educate them about peer pressure, encourage healthy friendship, provide strategy to resist peer pressure, and teach also critical thinking. They need to have critical thinking also. So I'll conclude the talk with that adolescents have a unique emotional and cognitive and social needs. We need to understand that. Emotional problems often lie beneath both behavioral and physical symptoms. We need to identify this. And understanding the emotional roots promotes early recognition and tailored intervention for the problem. Thank you. Thank you so much, Sudhir sir.
thank you, Dr. Manoj. If there are any questions, they can be typed in chat box and can be replied also there. Dr. Manoj, please excuse us for not giving you the time for replying online because the time is already short. Request
Yes,
Dr.
sir, no problem.
Dampuri sir to start the panel discussion after introducing their panelists. Thank you.
Thank you, Dr. Sudhir, and all the OB and EB members of the AHA. Is my screen visible? So this our screen is visible to
Yes,
you?
yes,
It
Dr.
is
Dampuri. Yes.
Right. Okay. So 1 minute. Right. So good evening all. Thanks. I thank all the OBEB of Adolescent Health Academy for giving the opportunities. So we have the most common thing which following the Manoj talk. So we have a panel on the psychiatric problems in adolescent. We have an excellent panel, esteemed and senior panel. So Dr. Prajapati is a Vice Chancellor of KM University, Mathura. He is formerly a Principal and Dean of Agartala Medical College and Director General of Medical Education. He has many associations and he has many publications to his credit. And our next panel is Dr. Joy Bahadur, a community pediatrician, and he worked at IAP in various level, in various capacities in the central IAP. So another panelist is Dr. Anirben Ray. He is a MD Psychiatry and Adolescent Psychiatry from Nimhans. He is a professor and head of Psychiatry Department, Jalpaiguri Government Medical College from West Bengal. And another panelist is Dr. Ishkesh Giruprasad. He is an associate professor from the Department of Child Psychiatry, Nilafar Hospital from Telangana. So before we start the panel, a brief introduction why we chosen this topic. So as my previous speaker and Preeti Galgal told, mental health, we know all the definition of the mental health, which encompasses the emotional, psychological and social well-being. It is not mere absence of the mental disorder. So this mental health, for overall well-being and quality of life, the mental health is more crucial for everyone, right from the child to the adult and adolescent. So if you see the adolescent, why we are addressing these adolescents? If you see the population from 1950 to 2050, they increased tremendously. And if you include the young adults, that will go almost 50% of our Indian population. It crosses 65 crores. So if you address the adolescents at a proper time, that will be a triple benefit for the society, community, and world at large, as per WHO. Healthy adolescent now, healthy adults in future, and healthy generation, future generation. So India has the largest number of the adolescents and young adolescents. If you address them correctly in all aspects, including the mental health, the India future is India's. So if we see a globally 1 in 7 between the 10 and 19 years old experiences a mental health disorders. 15% of the global burden of diseases is in this group is psychological disorders. If you this census from 10 to 14, almost 4.4 crores boys and 3.48 crores of women, girls in the age group of 10 to 14, and 15 to 20, it is 4.4 for the boys and 4.17 crores for the girls, which are being affected by the estimated mental health disorders in this age group. If we see the disease-wise, anxiety, depression, other mental disorders among the adolescents of this age group 10 to 19. So most of the things, almost 42% is by the anxiety and depression, apart from others. So it is the leading cause of mortality and morbidity in the aim among the adolescents, which if you don't address, definitely these will be crippling. So if you see how they are increasing from 2016 to 2023, so everything except the anxiety, all the problems are increasing in this period. So as I told, these are the leading causes of illness and disability among the adolescents. So they have depression, anxiety, behavioral disorders. What will happen if you don't address these things in the adolescents? They will have these conditions may go on to adulthood, impairing both physical and mental health and limiting the opportunities to the fulfilling the as adults. So now we go to our panel discussion. Dr. Prajapati, can you enlighten us? What are the common mental health issues in adolescents?
Well, thank you, sir. And a big thanks to all the central AHA team, Hema Bindu madam, Dr. Sudhir Mishra, and everybody for having a seminar on this. Regarding the question which the moderator has given me, that, sir, in your last slide itself, you mentioned that there are certain things on which the adolescents' mental health they manifest. And as you said, that adolescence is a period of significant change. Similarly, there are some mental problems, and at time that is a challenge. And it is how an adolescent behaves and tackles. About 15 to 20% of the adolescents, they experience problem. And the common ones, as you showed in your last slide, are the anxiety disorders, which manifest as worry and fear, irritability, restlessness, sleep disturbances, panic attacks, social withdrawal, etc. And in the mood disorders, there may be some anger, and if it further increases, there could be depression and then self-harm, etc., etc. Similarly, there are conditions like attention deficit hyperactivity disorders and the behavior disorders. A pediatrician and adolescent counselor should be able to realize this early so that the harm can be prevented. And usually they manifest as the decrease in the academic performance, the decrease in the social interaction, and the overall well-being. If these are picked up, then definitely we can help them in fighting out these things.
Thank you. Thank you, Dr. Prajapati. So, Dr. Jai, can you enlighten us what are the features of the most common mental health problem in the adolescent, that anxiety disorders, with which an adolescent will present in a OPD of a practicing pediatrician, live about the tertiary care hospitals?
Evening, sir. A very good evening to all the esteemed panelists and all the esteemed faculty, especially Dr. M.K.C. Nair and all the other faculty. And as we had agreed, this would be an extempore, but then at the last moment, I got panic-stricken and brought 2 pieces of paper. So that is what anxiety is all about. So we were talking about anxiety. So at the very outset, we would like to decide about the normal anxiety in the adolescents and children, which is part of growing up, and that which is clinical or pathological. So this has to be decided at the very outset. So what are the features? We could have these children or these adolescents coming with symptoms which are either physical or mental or psychological, whichever. Lot of this has already been said in the previous slides and by the previous speakers. We could have excess worry, restlessness, irritability, sleep disorders, fall in school performance. Worry to an extent that it sort of it differs from the normal worry. It would hamper my day-to-day life or the child's day-to-day performance or life, right? And the physical ones could be stomachache, headache, fatigue, restlessness, panic attacks, palpitation, muscular tension, cramps. Sometimes these somatic symptoms could overshadow the psychological or the mental symptoms. So we have to keep our eyes and ears open. It could be any of these. The worry and the anxiety could be of different types. You could have the SAD types, which is the segregation anxiety disorders, or you could have the GAD types, which is the general anxiety disorders. Some amount of anxiety would always be there in any normal child or adolescent if there is a segregation, maybe from the caretakers or from probably one school to other, or maybe one of his friends or her friends shifting from one school to the other. or going away, transfer. So these would be very normal. So we have to differentiate at the very outset whether this is a normal one or whether this is to an extent that it is hampering the child's day-to-day life. Right? This could probably get the child to an extent of social withdrawal, which could border on ADHD and conduct disorders. So,
Okay.
since we are just on the presentations, I will probably not go on to the treatment or the medications and such. So,
Yes.
is that all, or would you like me to go on further?
No, sir. This we will stop here with the features only. Then we'll come to the prevention aspect, other aspect in the next coming questions. Next, I will go to Dr. Anirban Ray. Sir, what are the features of mood disorders which an adolescent will present in the OPD? And another important thing, what a practicing pediatrician, can you tell us any tools or scales which you recommend to the pediatrician in their OP for a quick screening so that they can refer the case to the psychiatrist?
Thank you for inviting me for this panel. Am I audible clearly?
Yes, sir.
Thank you for inviting me first of all to this Central AHA program. Thank you for having me here. First, I will say that uh, basic thing what mood disorder can present with withdrawn behavior, uh, biological function deficit like a lack of sleep, lack of appetite, lack of energy, not having enough, enjoyment of what he or she was enjoying before. Those are the symptoms of depression. But in fact, in adolescence, these symptoms can be different from the adults. That's the most interesting feature in adolescence, because in two things are there. One is adolescence is a time when a child is going out from the family to the external world. So he or she will see that what he or she was thinking as a perfect, this is the ideal thing. It may not be always right, because when he's seeing the world outside, it may be different from their family, which they find that okay, this is also good. So what I was thinking as the only way of life may not be right. So these are the in adolescent people start exploring the identity. Those are identity role confusion. Those are the normative features. What a adolescent have normatively kind of less of self-esteem. Adolescents generally have low self-esteem than the normal child or even the adults, because that time when they start exploring, if they don't have the normal low self-esteem, they will not start exploring their life, and they will not reach the adults what they would be in future. So in adolescence the normal self-esteem is kind of low. But what the Joy sir was telling, that what is normative and what is more than abnormal, that has to be clarified further. So here, that if the dysfunction, what the Joy sir was rightly saying, that the dysfunction is very important, that the child's functioning, social functioning, family functioning, academic functioning, or whatever the functioning child is doing, is hampering because of this mood or not. That is very important. And the lack of energy, changes of biological function, those are hampering the child's life or not. And here the interesting part is, not always child is will present as behavioral withdrawn behavior. Sometimes the child can have express anger issues. Sometimes child can increase of ritualistic behavior. Sometimes child will you know faced with uh, some behavioral addiction or screen addiction. Screen addiction or behavior addiction can be an expression of the child's attempt of coping. What the our Manoj sir was presenting, one case was very interesting, that the child was forcing the family to change school because he was finding it difficult to achieve the same level of performance in the previous school. So it was the child's own solution to his problem. When the child is finding that no, he is cannot solve the problem, he is going into depression. So like that, a child, this is a attempts of coping the child in a different style to get things, get his problem solved. But when obviously the child cannot solve the problem all by himself or herself, so they go into depression. So here the red flags is the clear change of behavior. If the child has a clear change of behavior and there is a clear onset of that change of behavior, then we can we should think that we are dealing with the case of mood disorder. That's very important. And as you were saying that, scales, I'll suggest some scales. I am in a situation where I cannot share the scale. I don't have the laptop here with me. I have shared some scales in the WhatsApp group that which was created for this thing. But the scales are some revised children's and depressions, anxiety depression scale is 47 item scale is there. One is scared, that is screen for child anxiety and related disorder. One scared scale is there, it is also 41 item scale. So and another scale was there, the Center for Epidemiological Disease and Depression scale. It was also 20 item scale. So these are quite some in some longy scale. There was one scale that is pediatric symptom checklist, that is 17 item scale, but that not only deal with only anxiety and depression, that also deals with some externalizing symptoms, internalizing symptoms, those attentional symptoms. Those are the all the symptoms that actually screens. That also can be used, and those all are free. But I will suggest that rather than resorting to scales, scale is most often screen. One is screen, and one is obviously I mean rating scale. One there, but I have talked about the screening items only, screening scales only. But more than screening, a pediatrician has the benefit of seeing the child throughout his growing up. So they are the next person to the parents to know what the child is actually. So if they find some change, there is a clear change, and that is impacting, they will feel the difference. And at that point, and that suspicion is more important than the scale. I feel that the knowing the child very closely is very important thing in the whole scenario. If you we have all discussed about the Shahu has discussed, and about the thing that communication, open communication, the space for the communication, the safe space for communication is very important. If the child have a safe space for communication and non-judgmental this thing, then that will help the child. So I will stop here because I think the symptoms is what
Yes.
I suggest that we have done with, and we will further discuss about the management later on. Thank you.
Thank you, Ray. Here we will share all the scales in the WhatsApp group of AHA. And here I want to tell before I go to the Rishikesh. So what usually our teachers taught, Ray, is a happy child becoming dull or dull child becoming happy, totally different. That we have to suspect something in the child. So coming to Rishikesh, can you enlighten us, the Rishikesh, what are the ADHD symptoms which adolescent presents in the OPD?
Right.
Because this is the more child, in children, everybody they will do, but in adolescent
Adolescent,
age
yes.
group.
Yes, sir. So thank you for the opportunity. I'm a student of Dr. Jubilee Madam, and also my mentor. And thank you, Madam, for the constant encouragement. Uh, Basically, first to diagnose adolescent ADHD, the symptoms should start below 12 years of age. If you're diagnosing a case of 13 to 14 years of age, symptoms should start below 12 years of age, both inattentive and hyperactive symptoms. The presentation will be very atypical from the young age. And it is different with genders also, males and females. As Dr. Sahu was saying, females usually internalize things. They will present with anxiety and depression, or worrying about not performing well, emotional instability, weeping episodes, self-harming behavior. These can be the presentation in the OPD. In males, there will be most commonly externalizing disorders where there may be presentation with the continuous problem of opposite defiant disorder, where they'll be not obeying the rules, arguing, um, fighting constantly at home, anger outbursts, and irritability will be there, and fighting with the parents constantly. And they can go into conduct disorder. They can present with conduct disorder also with increased pathological lying, where they try to lie, steal money, and truancy, bunking the school regularly, and also substance use in some cases. Now I'm seeing increased trend of gadget use because of poor coping mechanisms in both the genders. The common symptoms in both the genders will be most commonly will be decline in scholastic performances. As the age grows, the performance decreases. They will be studying initially in the primary school very well, but as the age grows, there will be decline in scholastic performances, as well as increased irritability, and constant support for studies are needed from the both school and the parents, but still they can't perform very well, though the IQ is fine with them. So before going into diagnosing ADHD, IQ should be assessed and symptoms should start below 12 years of age, and presentation will be very different in both genders. And common presentation for OPD is not typical as ADHD, because as the age grows, more of inattentive cases will be there rather than hyperactivity cases. So this is the basic presentation, what clinical OPD is seen, what common cases will be seen.
Thank you, Rishikesh. So now I go to Dr. Prajapati. So we will be seeing a regular OPD on hospitals. But what are the usually we have a juvenile justice boards or CWCs, wherein even there also we'll be seeing the adolescents. So what are the common problems or issues with which an adolescent is brought before the juvenile justice board or to the child welfare committees?
Well, before I go to the presentation with which they are brought, a few lines about the Juvenile Justice Board.
Okay, sir.
That see, this is there in almost all the districts of India, and it comprises of a magistrate plus social workers, and these social workers, one should be male and one should be female, and they are specialized court-like bodies. They are not court, but they are court-like bodies meant to deal with the children who are in conflict with the law. And their aim is to, number one, provide care, number two, provide protection, and number three, rehabilitation. Now, if we take into these three categories, then the adolescents which present in these boards, those who come for care and protection are adolescents who are living on the street, where they are facing the risk and vulnerability of the not being taken care of. So they come here, and here they are protected and given support. There are certain adolescents who are abandoned and orphaned. They are also brought to the board, and with the same problems that they are having some conflict, misbehaving, doing some illegal sort of activities. So they come for the care and protection. Then there's other category of the adolescents who are engaged in the substance abuse, where they need to be rehabilitated. So the common things that they come is that they are smoking, they are drinking, they are lying on the footpath. And the main reason is that they have to be rehabilitated, and this is what the juvenile code does. And the most extreme part is when they come with offenses. These offenses, they could be minor, they could be major. In the minor one, is there they are involved in theft, they are having fight, and the most serious ones are when they do some sexual assault, they do some robbery, they may attempt to murder, or they may commit murder. So here the court, the juvenile code, first sees the nature, and because they cannot be punished being the minor, then they try to find, and the common disorders which I told earlier, like the anxiety, ADHD, conduct disorders, mood disorders, they are the things which are the main by which these adolescents they'll end up with the juvenile code.
Thank you, sir.
Can I add something, sir?
Dr. Joy, another two questions only, Sudhir. So, Dr. Joy, so now this is the era of the gadgets, right from the mobile to everything. Every adolescent is having all the everything in their hand. So, does the mobile dependency or the mobile will play any role in the adolescent psychiatric issues?
Right, sir. Yeah, just like my last answer, the anxiety disorders, this could also present with physical or mental symptoms. Since we are only concerned about the mental ones, the psychiatric disorders, the physical ones could be like eye problems, headache, musculoskeletal tension, and disorders. So we'll only concentrate on the psychiatric disorders. These are more or less like the anxiety disorder that we had in the adolescents. We could have depression and anxiety, which could result in mood swings, irritability, isolations. Then we could have a lot of anxiety arising out of FOMO, the fear of missing out syndrome that they call it, the sleep disturbances, social isolation, and reduced self-esteem, because you could have a lot of these spruced up false images put on this thing, which could result in reduced self-esteem of these children that are on the net, right? The curated profiles that the other people put as a mischief, maybe otherwise, these could lead to some amount of ADHD also, which some studies say, but then these are yet to be proved and further studies are required. Others like OCDs, alcohol and substance abuse can also arise from these. Why do these happen? Because this screen time or this prolonged blue time and the blue light and the screen time interferes with development of the prefrontal cortex, which helps us in decision making and the impulse control. And the blue light and the blue exposure also helps in the neurotransmitter secretions, and it follows the path of the reward pathway, which is similar to what we face in alcohol and drug abuse. So these could also result in these, like alcohol, they could run into alcohol and drug abuse.
Thank you, Jay. We have another two questions for two panelists. So now I request Anil Ben, how to address anxiety and depression in adolescents. Be brief. So we are passing the time. So briefly.
So thank you. The point is what I already told, that basically first when we find some anxiety and depression, first we have to make rapport with the child. That's very important, very, very important to allow the child to speak and allow the child to have rapport. This in this situation, when the child is anxious or depressed, the child is obviously reluctant to speak, may not speak that much, may be defensive, may be withdrawn. uh, it depends on the on the temperament of the child, but child will understand the genuine interest that we have. If we have the genuine interest of the child's problem, rather than don't solve the problem, try to understanding the problem. That's the perspective we need to change. So if a child understand that we are trying to understand his problem rather than solving it, then they will share, their problems, because they also want to share with their own what the difficulty is. They also want some solution, but what they find difficulty with, that all people are trying to not they we don't we adults are not not very keen to hear them. Rather, we want to solve their problem. That's their problem with. That's first very important. The psychotherapeutic approaches, that's very important. And another point is there. I felt that if we have difficulty in day-to-day activities, and we feel that there's a clear problem with the child, and sometimes there is suicidal ideations, or those things are there, then we can definitely give some medication. Medications are indicated, and when we have clear biological difficulty, lot of issues there, a lot of clear deterioration of their functioning and suicidal ideation, and especially some risk of hurting themselves, hurting others, or self-care difficulty, then we can start medication. And medications are indicated. Sometimes we have to be cautious in giving SSRIs. SSRI are giving in is generally given as a first line in case of anxiety or depression. But we in below 18, we must be cautious about prescribing SSRI, because SSRI can have activating symptoms, and it can give rise to the anxiety on anger issues, mood issue, aggravations of behavioral activation or angerness, what we call. Then we can give some, we may have to give SSRI under cover of some benzodiazepine, a small dose of benzodiazepine, or even under cover of some mood stabilizer. So we must be cautious about that, and in that way we can help.
Thank you, Ray. Rishikesh, so when a pediatrician should refer a adolescent to the adolescent psychiatrist, and up to what level pediatrician can do it is OPD?
So basically, any change of recent onset of behavior in both in male and females, basically, for example, a calm child becoming very aggressive, or a over socialized child become very calm, or disturbance in biological functions where there is decreased sleep and decreased appetite, or increased sleep and increased appetite, emotional instability, self-harm behavior, increased usage of mobile, decline in scholastic performances. These are the common presentations what we see in OPD. And when there is, these changes are continuously there, not on and off. Brief episodes can be there in adolescence, but if it is continuous and it is deteriorating, then probably that is the time where you have to refer it to a child or adolescent psychiatrist. From the pediatrician point of view, when you see a child at the starting point, because the first contact is you for the pediatricians, when you see, address the parents, because what can be the reason behind it? Whether it could be childhood ADHD, ADHD can be a problem, could be family patterns, or could be peer relationships, can be issues with substance or mobile addictions, anything can be there. So address that issue. General counseling can be done, and along with whole family should be addressed rather than the child itself. Not cornering the child. Don't corner the child in these issues. Tell the parents what should be done, and freedom with limitation should be given. Give the child some freedom and put the limitations, and see how the child is behaving. If it's still deteriorating, probably that is the time where you refer it to a psychiatrist. Thank you so
Thank
much.
you, Rishi. And I thank all the panelists. And with one sentence, I will close the panel discussion. Child or adolescent, whoever it may be, they will follow parents or adults, but not their advice. That is a single line, because usually parents, everybody will advise, but they don't follow their advice. They will follow the adolescent parents. Thank you. Over to Prakash Aryaji. Unmute karo, Prakash.
थैंक यू डॉक्टर दामपुरी सर, बहुत अच्छा है, आपने इंटरेक्टिव सेशन लिया एंड बहुत अच्छी तरह पैनलिस्ट ने डिस्कस किए पॉइंट्स. नाउ आई इनवाइट डॉक्टर जलील अहमद सर फॉर द नेक्स्ट सेशन.
Thank you, Arya sir, and thank you for the opportunity, this platform. My personal thanks to Hemabindu madam, Poonam Bhatia madam, and the president-elect Susma Desai and past president Geeta Patil. So this is the speakers are well touched upon the common issues, that is the psychiatric issues or mental health issues in adolescents. As it is mentioned by our Vice President Preeti Madam, the global burden is 13 to 15% in 10 to 19%. And we as a general pediatrician sometimes, especially during the 10th standard, 11th standard, coming with some mood disorders, anxiety or depression or low mood disorders. So to this, we have a very young and brilliant youth. We should listen to their voice regarding these two issues. We have Numika Khanna, who is a UNICEF champion, and we listened to her in previous platform also. And Guru Charan, another storyteller, to discuss about these issues. I will request Namika, how often you come across these issues, and what is your personal feeling, and when do you refer or when do you brought to the attention of a pediatrician or a specialist? Just to share your experience.
Yeah. So whenever I'm feeling overwhelmed or whenever I'm feeling sad or depressed, it is something that many of us actually go through.
Can you be a little louder, Nomika?
Yeah.
A bit louder.
Am I audible now?
No, or just
Better. Yeah.
Okay.
Yeah,
So I was just saying that whenever I feel overwhelmed, sad, or even depressed at many times, even during the time of my adolescence, whenever I'm feeling those emotions, I try to give myself a kind of a space to first of all acknowledge them. Sometimes what I do is I journal. I put my feelings into words, which helps me make sense of them. Sometimes I also choose solitude because, as it is rightly said, that solitude is one of the most important components that is required, but not isolation. A moment of quiet understanding is what I was going through, understanding within me. And one of the most important thing is that I have, through all of the conversations that we are having here, one of the most important thing that I've learned as a UNICEF champion was not to suppress my emotions, because in India I have felt that a lot of people do suppress their emotions, especially considering their school scenario. A lot of people do consider the school scenario, and a lot of people were mentioning that we focus a lot on trigonometry, algebra, Hindi, but not on life skills. Thus, suppressing sadness and stress doesn't make us stronger, it only pushes the pain deeper. So, whether it's through music, movement, art therapy, since I am myself a postgraduate in psychology, or even talking to someone I like, I try to honor my emotions and also give myself a grace to feel my emotions. It's a conscious decision, honestly, to respond with kindness instead of self criticism. And I honestly believe that sometimes every young person deserves to learn that our feelings are valid, and taking care of our own mental health is strength, not a shame or a taboo. That's it.
Thank you, Namika. What about Guru Sharan? What do you usually do when you are feeling overwhelmed or sometimes very sad? What is your experience in the reality, Guru Sharan?
Hi. Am I audible?
Yeah. Please go ahead.
I think my reaction is mostly I turn to reading and writing most of the time. And the second thing is I usually text my therapist for an appointment. And there are several things I do. I turn to animals a lot, actually. I turn to dogs most of the time. I think feeding them and taking care of another being, that helps the most. And of course, journaling.
How about do you think that we have discussed about the screen time or mobile social media? If the social media will help or worsen any the mental health issues in your personal experience, do
I think
you?
it does both. It helps also, but if we don't use it correctly, it's going to destroy also. It's going to exaggerate the problem, obviously.
How you counsel those who are using more screen time, your colleague or your peer? How do you counsel?
Naumika?
Okay.
Yes.
So me? Well, it's not just about counseling, it's more about I make them aware that first of all, since I live in urban area, I make them see that social media is something that of a double-edged sword. Although it does help young adults and adolescents like me find communities expressing themselves and also accessing various kind of mental health support and content, but it also creates some form of pressure, I would say, to look perfect, to always be happy, to compare oneself with others, something like cyberbullying, toxic comparison, toxic positivity, digital fatigue, and real issues that worsen our anxiety and self-worth. I would also like to take the context of rural India into consideration. For example, in rural India, smartphone access is rising to a huge extent. But here, digital literacy often lags to a large extent. So, social media honestly can expose adolescents to very harmful content. And without proper guidance, they can fall prey to a lot of issues. And the pressure to catch up and imitate the online trends can increase confusion, identity conflict, and especially when traditional values clash with online narratives. So while
Do you,
social media is a kind of today's lifeline, I do understand that without social media, our generation cannot live, especially. Uh, but I do suggest that the last session was on digital detox. While using social media, we can also practice the right amount of digital detox. That's it.
Guru, will the
Yes.
school can do anything for this students regarding these issues at the school
Um,
level?
Yes, I would like to add something here that there is also another issue with the algorithm. Like the algorithm pushes stuff that we want to see. It can make us go into a certain extreme ideologies, that this is the reality, and then we can form ideas that this is happening and that is not true. This is true. So that's a big issue, I think, and it can foster a lot of resentment towards a certain group of people, or resentment towards your own friends, family, or whatever. So that's another issue with social media. And I think schools need to have a subject of general mental health. I'm not saying that teach them psychology, but general mental health. Like they can have a subject like we had games period. We can also have a mental health period where we are just taught basic mental health things. I think that's very important.
Uh, uh, Vika, how about if you suspect your colleague suffering from this mood disorders, whom you should refer or whom you should go first?
Sorry, sir, I didn't get you. Your voice was broken. What
No,
did
who
you?
would you go first if you have some mentally struggling guys with you?
Yeah, okay. So first of all, in an ideal world, I would say that the first person any person would go to would be the primary caregiver, such as parent, teacher, trusted adult. But in reality, the scenario in India, like many of you explained, many adolescents and young adults are so fearful of being misunderstood, blamed, or told to get over it. So, in many of the contexts right now, such as in urban India and areas, some adolescents have access to counselors, therapists, and helplines that are available. But the stigma and the taboo still exist in our society. Many hesitate to even reach out due to the shame or fear of being seen as weak. Or I would say that, for example, there's a quote called "मर्द को कभी दर्द नहीं होता, but honestly होता है और होना चाहिए भी." In rural India, the situation is more challenging. For example, there are fewer trained mental health professionals and emotional struggles that are often dismissed or spiritualized, I believe so. Um, and so that so many adolescents turn to their peers, or worse, suffer in silence. And sometimes the misinformation that they get from peers, the loneliness that they suffer, could also get converted into a lot of other disorders. And for example, the case of Punjab, we have the highest substance abuse rate. It is because so we are left alone. There is nobody to explain to that. But I guess it could be, it could be built through by youth-friendly support systems, from having very good school counselors to, having peer mentors, facilitators, helplines like telemanas, and introducing more honestly and emotionally aware families, so that we can also conduct some form of workshops for them, so that every adolescent, no matter where they live, knows that they are not alone and that help is available. There is a peace of mind that every adolescent has in their heart, in their head.
Thank you, Nimika. Since this is the innovative program of our President Hema, I will ask both of you in a single word the message, that is the youth voice, as far as this mental or psychiatric issues are concerned in this adolescent. A message to the people. Both of you.
Well, the message for what I would like to give is you are not alone, is what I would like to say. You are not alone. And another one that I would like to give is it's okay to not be okay. It's a very famous one, I guess.
Yes, yes. What about Guru Sharan?
Okay, so I would like to say that don't be afraid to speak your truth.
Yes.
Just don't be afraid to speak your truth. And like, your experience matters, your emotions matter. Whatever you are experiencing is, there is a reason behind it, and you don't have to feel ashamed about it. So express yourself in any way possible.
Thank you both, Namika and Guru Sharan, on behalf of AHA Central and on myself and Hema Bindu Madam. This is a wonderful process. Thank you very much.
Thank you.
To Samir sir.
Thank you, sir. Can I just put my little comments, Dr. Arya?
Yes, madam. Yes, madam. हिमा बिंदु
Yeah,
मैडम
yeah.
आगे
Yes, yes.
एक्सपर्ट करो.
So आज हम बहुत अच्छा लगा, पूनम जी का पहले स्टार्ट हुआ और इतना मतलब she is so artistic, so creative. It was such a wonderful session to see the release of the second thing, and the getting Dr. MKC Nair sir and CP Bansal sir was the bilkul icing on the cake. And they are the mentors. They are the ones who have mentored us and brought the adolescent health to the forefront. So it was really a blessing to have them. And the topic today on psychiatry, again, it was usually here in a very routine way, standard, but today we got multiple, perspectives from a psychiatrist, from different pediatricians from Jamshedpur, from Hyderabad, and Dr. Sudhir Mishra, sir, thank you to get them all on board. And Dr. Ramesh Dampuri, our EB member, our executive board member of Central AHA. Thank you, Dr. Ramesh. That was wonderful to get the, the association between mobile phones, mental health, and, it was very new things discussed. Thank you. It was a very good moderation to capture all the new aspects. And I would love to also put my comments on this young people. And Jalil, sir, the way you have interrogated, candidly spoken to the young people, that was so great. It was so spontaneous. And I hope you enjoyed interacting with these two young, our youth voice. And Dr. Nomika, thank you. You are always connecting us with a lot of young people throughout, and though we got connected with UNICEF first, and you have now, we have become part of our AHA family, AHA Youth Forum. Thank you. And Guru, you also, spoke from the heart. And I love that last messages you both said. We are not alone and express, and it's okay to be not okay. I think that is so good. And yes, we don't need to be perfect. We don't need to look as if we have no problem. Everybody has, and it's okay to sometimes be low and open up and even cry, no problem. So we need to know how to cope up and bounce back. That is what we all have to learn. Thank you. And Dr. N.C. Prajapati sir and all the seniors who are here. Thank you, all of you who have been part of this journey of AHA. Thank you so much once again from the Central AHA as a chair. It is very, very heartening to see.
Hima, I would
Yes,
like to
always there.
congratulate to
Oh, sir,
young
you're
girls.
still there, MK Sinai, sir. Thank
Yeah,
you.
I just
Sorry,
want to
sir.
congratulate to Namika and the other girl. They've done a wonderful job.
Guru. Yes, sir.
Both of
Yes,
them
sir.
have done a wonderful job. Actually, I was waiting the whole time to listen to them.
Wonderful,
The
sir.
rest we have heard many times, but I
So
wanted
nice.
to hear more from the youngsters.
Sir.
And the interview was fantastic, very
Sir.
superbly done. I was quietly sitting and listening to the whole thing last 1.5 hours.
Yes.
Thank you all very much. Thank you.
sir. Thank you.
It's a wonderful effort.
Thank you for having me here. Thank you.
Yeah, Bushran has made
Yes, Namika, actually your voice is too low today.
हाँ थोड़ा सा
You have to remove your, I
स्पीकर
think
की
your
प्रॉब्लम है कुछ
Krishna is from which part of Punjab?
I am from Chandigarh. Same
Chandigarh.
Namika.
Okay, I am also a Punjabi by education. So I was, after a long time hearing the call, suddenly it struck me that I should talk to you. Okay, Kaur and Khanna and all those names that I have not been using it very frequently nowadays.
Gone back to those college days.
I was in Louisiana from 1970 to 80.
Yeah.
10 years.
बहुत सा 10 साल पूरी
So that's why I was very much fascinated to listen to your ideas.
Thank you, sir, for staying with us till late night. Thank you.
Good night. Good night, all.
Good night. Good
Good
night.
night, everyone.
Dr.
Thank you.
Shamik
Thank you. It
Ghoshji.
was a great opportunity to be here.
Good night, all. Good night.
Good night, sir.
Good night.
Now I invite Dr. Shamik
Good night,
Ghoshji for formal
Good
vote
night.
of thanks. सदैव प्रश्न रहने
Thank
वाले
you,
energetic
everyone.
age.
And
Dr. Shamik.
thank you so much, Dr. Prakash. And it has been wonderful just being an audience. We've had some very effective messages being passed across today, some very relevant points being discussed. We've been blessed by the presence of our mentors, Dr. M.K.C. Nair and Dr. C.P. Bansal, Dr. Preeti Galtili, and everyone else who is scared to, spend some time with us. Adolescence can be variously described as a horse ride. It's going to be bumpy, and yet we are going to be having some speed at some point in time. We need to hold back. And mental health in adolescence is like walking in the rain. You can feel the rain, but there's no need for you to think that you are the rain. So all those messages, let's take it and put them into practice. Thank you to everyone who attended today, and we at Central AHA, we will continue to be holding these very relevant super specialty webinars, and we will soon be back in a month's time with the next one. Thank you. Good night.
Good night.
Thank you. Good night. Good night.
मिलेंगे 18 को मिलेंगे सर.
Good night, all of you.
Good night.
Good Shamik is a wonderful backbone.
Thank you.
Thank you.
Thank you.
18 को
Bye-bye.
मिलेंगे wave 18 में.
Yes, wave 18 hai. Yes.
18 को.
Thank you.
Thank you. Good night.
Thank you. Thank you, Hema Bindu madam. Good night. Good night.
Thank you, sir. Thank you, all
Good
of you.
night.
Thank you.
Good night.
Good night.
Prakash sir, good night.
Good night.
Arya sir, good night.
Sir.
Rashmi ji, good night. Gursharan ji, good night. Srinivasan sir, good night.
Good night, sir.
Good night, sir.
Arya, sir, you can end the thing. We need to also have sleep hours. Thank you. Thank you all.
It was a wonderful session, Hema Bindu madam. Great session.
Thank you, sir. Thank you so much.
I am from USA na. I am with my daughters na.
Oh,
Till
you are gone there,
16th.
sir.
Yeah,
Acha,
I
acha.
joined. So from here, I'll say good morning, but
I know.
good night
But
to
yes.
India.
Good, good, sir. Enjoying. Thank you. All the best.
Okay,
Thank you,
ma'am.
sir.
Okay. Thank you, ma'am. Thank you.